Hello, my name is Hector Vasquez. I'm currently a P4 student at Albany College of Pharmacy and Health Sciences. I will be doing a patient case presentation on one of the patients we encountered at Champlain Valley Physicians Hospital. We will be going over her medications, her history of present illness, and anything that's related to this patient. So let's begin. Let's start off with the history of present illness. And DH is a 67-year-old female patient with a past medical history of cardiomyopathy, an ejection fraction of 45 to 50% per echo, and a history of paroxysmal atrial fibrillation, congestive heart failure. She came into the hospital by transfer from Adirondack Medical Center for atrial fibrillation. The patient was originally cardioverted there, but reverted back into AFib, and she was transferred to our hospital to further evaluation and treatment. After being evaluated, the patient was deemed to be a good candidate for antiarrhythmic medication, and she was started on Ticastin, which she received 2 doses of. The EKG confirmed was appropriate, and the QE interval before the second dose was within normal limits. The second dose was authorized. Unfortunately, after that, the patient went into torsades, and she required cardiac shock to bring her back to normal. Reviewing her telemetry suggests that prolongation of the QT interval afterwards was pause-related torsades to points. So let's get started. Let's begin with the history of present illness. DH is a 67-year-old female patient with past medical history for cardiomyopathy, an ejection fraction of 45 to 50% per echo, and a history of paroxysmal atrial fibrillation, congestive heart failure, and came into the hospital by transfer from the Adirondack Medical Center for atrial fibrillation. Originally, the patient was cardioverted there. She reverted back into AFib, and she was transferred to our hospital for further evaluation and treatment. After evaluation, the patient was deemed to be a good candidate for arrhythmic medication, and she was started on Ticastin. She received 2 doses of. EKG was confirmed appropriate by the PA, and the QT interval was within limits for both doses. As such, both doses were authorized. Unfortunately, after that, the patient went into torsades, and she required a cardiac shock to bring her back to normal. A review of telemetry suggests that prolongation of the QT interval, and afterwards a pause-related torsades to points. Because of this, the Ticastin was stopped and the patient was transferred to the ICU, where she continues to have episodes of non-sustained ventricular arrhythmia, torsades. Patient complained of nausea and diaphoresis, and her baseline heart rate was slow. She was then initiated on magnesium and isoproterenol for the episodes. Patient also had a cardiac catheterization that showed no CAD. We'll go in depth on the use of these medications and see what happened, and also discuss if there's anything that could have been done differently, what was done correctly, and go over her entire list of medications. As discussed in our section for history of present illness, our patient has a medical history of atrial fibrillation, cardiomyopathy, hypertension, and congestive heart failure. For her congestive heart failure, the patient was taking torsemide and spironolactone, but they are not important to this case. However, there's a third medication, digoxin, which she was taking for congestive heart failure and her atrial fibrillation. We will discuss this on a later slide on the importance of this medication and why it makes it so interesting in this case. As discussed in the history of present illness, our patient has a medical history of atrial fibrillation, cardiomyopathy, hypertension, and congestive heart failure. It's important to look at the congestive heart failure as she was taking 3 medications. All of them were discontinued before the initiation of the Ticastin. Those were torsemide, spironolactone, and digoxin. That last one is the one we will look at for the rest of this presentation, as it is vital to understanding what happened with this patient. As for her physical examination, she was alert and oriented times 3, a little anxious, seemed depressed. Her blood pressure was 132/59. Her heart rate was regular and sitting at 59. Respiratory rate 18 and was afebrile. Her head, eyes, and nose and throat were normal. Her neck was supple, no JVD, no thyromegaly, no palpable mass. For her heart, S1 and S2 were irregular, lungs were clear to auscultation, and her abdomen was soft and non-tender. In terms of her physical examination, she was alert and oriented times 3. She had anxiousness, seemed a little depressed. Her vitals, her blood pressure was 132/59. She had an irregular heart rate of 59, respiratory rate of 18, and afebrile. In terms of head, eyes, ears, nose, and throat, everything was normal. Her neck was supple, no JVD, no thyromegaly, no palpable mass. In terms of her heart, S1 and S2 were irregular. The lungs were clear to auscultation, and her abdomen was soft and non-tender. Some labs that are important to look at, she had a TAD-VASc score of 4, meaning that the apixaban that was prescribed for her was appropriate. A serum K of 3.9, a serum MAG of 2. Her creatinine clearance was 83, and she had a target heart rate of 100 beats per minute. This was after the Torsades event. This was something that the doctors wanted to aim towards to maintain some sort of normalcy within her heart rate. With that being said, let's go over her medications. The medications we're going to go over first are medications that aren't directly primarily linked to the situation, to the condition, to the torsades that happened with our patient. So let's begin with our peripheral medications. These were potassium chloride, 40 MEQs, PO. This was just used to maintain her serum potassium within normal limits. Her dexmedetomidine was used for sedation, both in the ICU setting to maintain a semblance of control with the patient. Sucralfate was used to maintain and control an active ulcer. She was also on hydrocortisone, 2.5% BID topical, for an occurrence of a rash she had on her back. Lorazepam, 1.5 milligrams IV push. This was used for two things, as an antiemetical medication and as an anti-anxiolytic. The patient had said she was anxious and she was feeling nauseous, and lorazepam was used for prevention of both. Pantoprazole was used in the ICU, again for prevention of stress ulcer prophylaxis. And apixaban, we've already seen that there was a TAD-VASc score of 4, which meant it was appropriate to start apixaban on this patient. And then the ketorolac was used for general analgesia. So if the patient was in any pain or required anything that needed soothing, the ketorolac was there for her. Continuing on, we will now go over the medications that are intrinsically linked to our event, that being the torsades. These medications were used either for treatment of the torsades or were the cause or the initiators of our event. Starting off with digoxin, the dosing is there. It was used for our patient's heart failure and her AFib. This medication was discontinued before initiation of our second medication, the dofetilide. The dofetilide was used as a rate control for an arrhythmic medication, as it was deemed that the patient needed a class 3 antiarrhythmic for her persistent AFib. This was deemed appropriate and was dosed at 500 micrograms BID. Unfortunately, over the course of the night, the medication sent our patient into torsades. That's why the next three medications were used. Magnesium sulfate, atropine, and isoproterenol are all medications used to reverse torsades. Magnesium was used first for our events. As the patient kept going into torsades, the magnesium wasn't enough, and isoproterenol was indicated. The atropine was used as a gate, as a bridge between the magnesium and the isoproterenol before the isoproterenol could get there, and that is why the atropine was used. Finally, when the isoproterenol was there, it was kept until the dofetilide was out of our patient's system. After this, the patient was transferred to the ICU, as we know, and was in need of rate control. At first, she was started on esmolol, 25 milligrams IV, continued then on metoprolol XL, 500 milligrams, also diltiazem, 100 milligrams IV, and for treatment of her AFib, we had to commence amiodarone. Ampicillin sulbactam was also something that was started as there was some sense that the patient might have possibly had pneumonia, but that is something we will go over in our next slides. So let's take an in-depth look at our patient and her atrial fibrillation. Was the dofetilide indicated? Was it dosed correctly? So, dofetilide, or Tecocin, is dosed off of a patient's QT interval. Normally, for a patient to be initiated on it, the QT has to be under 440, with the exception of a patient who has a ventricular arrhythmia. As our patient had rapid ventricular response, she falls in this camp, which means that her baseline of 444 is underneath the cutoff of 500 milliseconds, meaning that initiation and initial dosing were correct. An EKG is also indicated to be gotten after every dose for the first 6 doses and then heavy monitoring. So our first dose, after her first dose, she had a QT of 420.9 milliseconds. The patient was in sinus rhythm and everything was looking fine. Patient received a second dose, off of which she went into torsades, and she required defibrillation and CPR. Obviously, the medication was DC'd, and is a medication that has a decently long half-life of 10 hours. So, what went wrong? What do we find here? We will keep discussing this. So let's take an in-depth look at our patient's atrial fibrillation. First off, was dofetilide indicated? Was dosed correctly? Let's find out. So dofetilide normally is dosed based off of a patient's baseline QTc. The normal range you want to have is below 440 milliseconds of a QT. However, it can be lower than 500 in patients who have any type of ventricular arrhythmia. As our patient had rapid ventricular response, she falls in this camp, and her baseline QTc of 444 milliseconds is beneath our cutoff of 500 milliseconds. The dosing for this would be 500 micrograms, which is what the patient got, and would be deemed appropriate both for initiation and for correct dose. It is also important to get a QT after every dose for the first 6 doses with heavy monitoring. The first QT that we got back after our first dose was 429 milliseconds. The patient was in sinus rhythm and her heart rate was 56 beats per minute. A little bradycardic, but everything seemed to be looking fine. It is after our second dose that our patient was sent into torsades. She required defibrillation and CPR. Needless to say, the medication was DC'd, and seeing that the medication has a half-life of 10 hours, then there was other medications that were needed in order to control our patient's rate and our patient's condition. What were these? Well, our patient was already on toprol, which had to be lowered to 25 milligrams a day. Originally, the beta blocker we used for rate control was Esmol at 250 micrograms per kilogram a minute. It was DC'd on 8/29 as the rate control was inappropriate. As we will see later on, the patient's heart rate kept going up and down. There was no real control. This is why we had to initiate a diltiazem drip, dripped at 5 milligrams per hour. So a timeline of this, in 8/28, the patient had a VTAP with a max rate of 250 beats per minute with a low of 80 and some bursts of SVT. On 8/29, her heart rate was between the 120s and 160s, consistently going in between the 130s. During 8:30, she had an irregular heart rate between 120 and the 150s. The drip had to be increased to 10 milligrams per hour, and she kept having frequent PVCs. In 8:31, she had a MAP of 57. Her heart rate fluctuated between 70s all the way up to 160s. Diltiazem was DC'd, then reinitiated at 5, then up to 7.5 mg per hour, along with initiation of amiodarone for control of her arrhythmias. Now, let's look over the medications that were used during our torsades event, starting with our offending agent, the dofetilide. As we said, this was probably the medication that sent our patient into torsades, and our patient would need medication for reversal of this. Our first reversal agent was magnesium sulfate. It's normally the drug of choice. It suppresses early after depolarizations and terminates arrhythmias. Normally it does this by decreasing the influx of calcium and lowers the amplitude of the EADs. As the patient had more than one torsades event, the magnesium wasn't enough, and we had to use other agents. Normally, you would use isoproterenol. However, our patient had RONT phenomenon, basically making the patient dangerously bradycardic and needing something for that. So we use the atropine as the atropine suppresses torsades by speeding up the heart and has direct effects on ventricular refractions. As it was used as a bridge before the isoproterenol got there, after which the isoproterenol was initiated for a target of 100 beats per minute. It was infused at 8 micrograms per minute, and it was used for the bradycardic dependent torsades. Normally, you want to shorten up that QT interval that was prolonged by these medications. Isoproterenol is really good for drug-induced torsades. So, as we had already discussed, dofetilide has a half-life of 10 hours, and you want to keep isoproterenol on longer than that. So you keep it on for 4 extra half-lives after the dofetilide to make sure that the drug is completely out of our patient's body. As we had seen at the bottom of our medication list, there was ampicillin phylbactam on our patient. Why was this? Well, after the resolution of our patient's torsades, there was an opacity foul in her lower right lobe. She also developed a low-grade fever and leukocytosis. As the patient had been hospitalized for about a week and a half now, there was significant risk of the patient developing pneumonia, for which the ampicillin phylbactam was initiated for prophylaxis. After a couple of days, it was self-resolved and the ampicillin phylbactam was discontinued, as it was most likely a result of a release of tumor necrosis factor due from the fractured ribs that the patient received from her CPR. As we have seen, this patient has been tricky to manage both on her rate and her rhythm, as she has been in constant AFib throughout this entire time, and her rate has been down to the 50s all the way up to 250 on one day for her VTAC. So the plan was to cardiovert her, of which she only needed a single shock and went into bradycardia. After a couple of hours, the patient reverted to AFib, and later that day, she spontaneously converted to sinus rhythm. We can say that the use of amiodarone was successful because how amiodarone works is that it blocks the potassium currents that cause repolarization of the heart muscle during the third phase of the cardiac action potential. Normally, this isn't a drug you want to use for atrial fibrillation. However, since this was a prolonged case of AFib, along with RVR with ventricular arrhythmias, then amiodarone proved to be the drug of choice, both successful and helpful for this patient. The plan will be to continue the use of amiodarone and keep monitoring this patient to see if anything happens, see if she can be maintained on this medication. In the end, the physicians concluded that the torsades events were most likely precipitated from concurrent use of digoxin and dofetilide. Even though the digoxin was discontinued before the initiation of the Tikecin, having both in the body means that the concentration of dofetilide can be increased, meaning that with it having a longer half-life, it can stay in the body and most likely throw the body into torsades. Another explanation can be that the dosage of dofetilide, although appropriate, has been known to be the most likely to throw people into torsades. So 500 micrograms of dofetilide is the dosage that most likely causes torsades. As a patient will have continuous AFib for a while. The patient was educated on AFib. She was given an education on it, and she was discharged. And there was a plan for discharge after a week of observation. Although she is still in sinus rhythm, it is something that she'll have to monitor for the rest of her life. Amiodarone will be continued as it is the agent that has proven to be effective with this patient, and this patient will need to continue to be monitored for the foreseeable future. Thank you for your time. I hope this has been informative for everyone, and I hope everyone has a great day.